healthcare brothers and sisters. I hope that you are having a wonderful day. The 2020 updated guidelines are out for the American Heart Association's basic life support. And today we're going to be discussing what 2021 will hold for us when it comes to BLS. Let's get started. So one of the big changes that you're going to see to the 2020 guidelines is the change in the chain of survival. So what the American Heart Association did was they added a sixth link called recovery to the end of the chain survival. So really, once we get that return of that spontaneous circulation, it's really about the care and support during the patient's recovery. So they recommended that after cardiac arrest, these survivors should have multimodal rehabilitation assessments and treatment for physical, neurological, cardiopulmonary, and cognitive impairment. So when it comes to our basic life support, it's really all about that CAB, our compressions, airway, and breathing. So when we find a potential victim, we want to check for responsiveness of that patient by tapping firmly on them and above their collarbone. If there is no response, and I'm talking about you really need to tap, are you okay? If you find no response, you want to assess the environment for safety before beginning cardiopulmonary resuscitation. Why? Is because if you're out in the middle of the street and there are cars moving back and forth, you can potentially become a victim yourself. And if now we have two victims, it's going to be a lot harder for people to do cardiopulmonary resuscitation on two people as well as activate the system. So make sure that you are in a safe area before starting CPR. Next, you want to activate the emergency response system by shouting for help and have another person obtain an AED or defibrillator. Something new that is recommended with the 2020 guidelines is that if you have a mobile device, they want you to immediately activate the emergency response system as opposed to waiting for help, because the quicker that you can get help to you, the quicker we can save lives. Next, you want to check for breathing and a pulse no more than 10 seconds. We don't want to delay that life-sustaining cardiopulmonary resuscitation. Next, you want to begin CPR if there is no pulse detected by starting chest compressions, and these are high-quality chest compressions. However, if a pulse is present and they have agonal breathing, then we want to begin rescue breathing immediately. Like I said before, the 2020 guidelines have updated regarding the activation of the emergency medical services. So if you have a mobile device, it's available, it's handy, you want to call early. You don't want to wait for help if you already have the resources you need in order to activate the system. So any area outside the hospital, such as a parking lot, make sure you activate that system as soon as possible. So let's talk about chest compressions. You want to place the palm of your hand over the patient's sternum just above that xiphoid process. A previous indicator in the past updates was that the hand should be placed at the mid-nipple line. However, due to the increase in obesity, the nipple line may not be the best indicator when it comes to CPR. So make sure that you're placing the palm of your hand just above that xiphoid process on the sternum. When it comes to chest compressions, we want to do between 100 and 120 per minute. And in adults, we want to compress at least 2 inches. You also want to allow for full chest recoil between compressions and minimize interruptions to less than 10 seconds. A lot of these that you see in red will be on your exam. You want to switch compression team members every 2 minutes to avoid exhaustion of CPR. Lastly, compression to ventilation ratio. When it comes to adults, you want to do 30 chest compressions to 2 rescue breaths. Something new that the American Heart Association is implementing as 2020 is the CPR coach. And what this coach does is it's really dedicated to the quality of CPR. They're critiquing the depth, the rate, and the recoil. And this role can be combined with another role, such as somebody who's going to be handling the defibrillator. It's really just a second person looking at CPR to make sure that we're doing it effectively and efficiently. So let's take a look at the airway and breathing when it comes to our CAB. In our adult patients, we want to utilize that head-chin lift or draw thrust if there is a chance of cervical spine injury related to trauma. We're going to provide rescue breaths, 1 breath every 6 seconds for respiratory rest with or without an advanced airway. This is a new guideline for 2020. It used to be that you had differentiating ways of providing rescue breaths depending on what you had. So if you had a bag mask valve device, then you would provide one breath every 5 to 6 seconds for respiratory arrest, or one breath every 6 seconds for ventilation with an advanced airway. However, they have now changed that for 2020 to make it a little bit less confusing, and now it is one breath every 6 seconds for respiratory arrest with or without an advanced airway in place. You want to make sure that you're seeing visible chest rise and fall with each rescue breath, and you also want to avoid excess ventilation because there is a potential reduction of cerebral blood flow related to a decrease in CO2 levels if we are excessively ventilating these victims. Let's have a discussion about the AED and defibrillator. What is the first thing you want to do whenever the AED arrives to the scene? You want to turn it on and you want to follow the prompts provided by the AED. Next, you want to open and remove the person's shirt. Now, if this is a potential person who's very sweaty because of an MI or they are a near drowning patient, you want to make sure that you clear that wet barrier prior to putting the pads on. It's also important that if you find any medication patches on the chest or the back, that you also remove those as well. Next, we're going to attach the AED pads to the right anterior chest and left mid-axillary line per the pad instructions, and we're going to plug the pads into the connector located on the AED. We're going to stop chest compressions and confirm that everyone is clear by saying stand clear. You want to make sure everybody hears you. You're going to push the analyze button on the machine and allow the AED to analyze that person's heart rhythm. If a shock is recommended, you want to again check to make sure that everybody is clear and no one is touching the person by saying stand clear. Once everybody's clear and you've confirmed it, go ahead and hit the shock button. And after the shock takes place, you want to make sure that you begin CPR immediately. If no shock is advised, again, you're going to start CPR immediately. You're going to perform another 2 rounds of CPR and then again follow what the AED prompts tell you. Something that's really important to know when it comes to BLS is when we do termination of resuscitation. Now, if we're out in the field providing BLS to a potential person, then we don't stop BLS until somebody gets there. We want to continue to try to save lives. However, if in transit or when we get to the hospital, it's really a discussion that we have as a multidisciplinary team of when we decide to terminate resuscitation. There's certain criteria that has to be met. One of the criteria, arrest not witnessed by emergency medical services personnel. 2, no return of spontaneous circulation before transport. And 3, no AED shock was delivered before transport. If all of this criteria is present, that is when we start to consider termination of resuscitation. If any of the criteria is missing, we want to make sure that we're continuing resuscitation and we're transporting the patient to the hospital. Now let's take a look at the basic life support when it comes to pediatric persons. We really need to understand the definition of neonate, infant, child, and adolescent because depending on what age group they fall in, it's really going to affect how we provide basic life support. When it comes to our neonate, they're going to be between 0 to 28 days. Our infant is going to be between 28 days to 1 year. Our child is going to be greater than 1 year, but they have not reached puberty. And when it comes to our adolescents, puberty will be present either through armpit hair or breast development. So when it comes to basic life support in our pediatric patients, we're again going to follow that CAB sequence for cardiopulmonary resuscitation. That's our compression, airway, and breathing. You're going to begin by verifying the scene is safe so that you don't become a victim yourself. You're going to check the patient for responsiveness by either tapping on the shoulders or you can tap on the heel if it's an infant patient and shouting, "Are you okay?" If the victim does not respond, you can shout for nearby help and activate the emergency response system. Again, the 2020 updates have advised that if you have a mobile phone, you yourself can activate that emergency response system immediately. If nobody responds to you, you do not leave the child. So if you don't have a mobile phone, you're unable to call someone, and nobody is around you, you don't leave the child. You want to first perform one round of CPR prior to going and finding help. Next, we're going to assess for our breathing, no more than 10 seconds. We want to check for rise and fall of the chest and if there is a pulse present. When it comes to pulse checks, in our infants, we're going to palpate that brachial pulse, and in our children, we can either palpate the carotid or the femoral. If we have an unresponsive, no breathing, no pulse pediatric person, then we're going to begin CPR immediately. Now, when it comes to our infant patients, one of the 2020 AHA guideline updates is there are now options for single rescuer CPR hand positions. So in 2015, the only hand position you could use was the 2 fingers on the center of that infant's chest, the lower half of the breastbone. You also have that option in 2020, but you can also do 2 thumbs at the center of the infant's chest, lower half of the breastbone, or 1 hand in the center of the infant's chest, lower half of the breastbone. So whatever is more comfortable for you, you now have options in 2020. 1 person rescuer for infants is 30 chest compressions to 2 breaths. If you by chance have a second person rescuer, it now switches to 15 chest compressions to 2 breaths. And the reason is because it provides for better coronary perfusion. When it comes to a child, you can either use the 1 or the 2 hand method. Chest compression should always be 1/3 of the AP diameter of the chest. So when it comes to infants, that's approximately 4 centimeters. Children, approximately 5 centimeters, and no chest compressions in our pediatric persons should go beyond 6 centimeters. Chest compressions should always be between 100 and 120 per minute, regardless if they are an infant, child, or adolescent. So let's talk about the 2020 American Heart Association BLS updates when it comes to pediatric rescue breaths. So after you perform every round of chest compressions, as the provider, you want to provide rescue breaths. So you want to provide 1 breath every 2 to 3 seconds, so that's approximately 20 to 30 per minute, with or without an advanced airway. If you're providing CPR and there's an advanced airway in place, then you want to give 1 breath every 2 to 3 seconds. Again, that's between 20 to 30 breaths per minute, accounting for the age and the clinical condition of that person. Infants, it should be at least 30 breaths per minute, and when it comes to older children, we want to be providing at least 25 breaths per minute. You want to make sure that you're seeing visible chest rise and fall to confirm that the rescue breaths we are providing are appropriate. You also want to place the patient in a sniffing position for optimization of rescue breaths. This really requires that you provide flexion and extension of the head and neck using that EC method if you're using a bag valve mask. Let's look at what the differences are when it comes to AED pad placement with our infants and our children. If we have a potential person who is under the age of 8 years old, you want to always use the child pads if they are available. Some AEDs may not come with child pads, and if that is the case, we can use the adult pads just with a little variation. You want to place the pads on the potential person so that they are not touching each other. That means that 1 pad is going to go on the chest and the second pad is going to go on the back. The pad should really create a sandwich between the heart if they are placed appropriately. If you have a potential person who is 8 years of age or older, you always want to use the adult pads. Do not, under any circumstances, ever use child pads because they will likely not provide the shock dose that is required in order to help restart the electricity of the heart. Upon our assessment of the person, if they have a pulse but they are experiencing agonal breathing, CPR might not be necessary. We do, however, want to provide rescue breaths, 1 breath every 2 to 3 seconds. Again, that's 20 to 30 per minute, with or without an advanced airway. When it comes to IV-IO access, IO is still the preferred access for cardiac arrest in pediatrics over IV access. When it comes to electrical resuscitation of our pediatric persons, we have 2 options: defibrillation and synchronized cardioversion. In defibrillation, it's a treatment for immediate life-threatening arrhythmias with which the patient has no pulse, such as ventricular fibrillation or pulseless ventricular tachycardia. The initial shock we can provide is 2 joules per kilogram. If a second shock is needed, we provide 4 joules per kilogram, and each subsequent shock thereafter should be greater than or equal to 4 joules per kilogram. We would never want to provide a shock over 10 joules per kilogram. An easy way to remember this is 2, 4, 6, 8. That's the dose to defibrillate. When it comes to synchronized cardioversion, it's a treatment that aims to convert an arrhythmia back to sinus rhythm, such as atrial fibrillation and supraventricular tachycardia. We typically use between 0.5 to 1 joules per kilogram when it comes to synchronized cardioversion. Now let's talk about foreign body airway obstruction in our adults and children. We begin by asking the potential victim, "Are you choking?" If that victim nods yes and cannot talk, there is a severe airway obstruction present. Something really important that I want you to note. Your next question should always be, "Can I help you?" Most of the time your victims are going to say yes, but there are times where people are going to say no, either out of fear or anxiety or whatever their case may be. If they say no, you do not touch that potential victim, because if you touch them and they didn't want help, it is considered battery regardless of your clinical background, if you had one or not. So once they collapse and they are unresponsive, consent at that point is implied, so you can begin CPR. However, if they have given you permission, you want to begin by providing abdominal thrusts like the Heimlich maneuver or chest thrusts for pregnant or obese patients who are responsive. You're going to repeat these same abdominal thrusts or chest thrusts until the treatment is effective or the person becomes unresponsive. So let's talk about foreign body airway obstruction when it comes to our infant victims. If the victim cannot make any sounds or breathe, we know that there is a severe airway obstruction present. We're going to begin by placing the infant prone, and we're going to give 5 back slaps, and I'm talking some good back slaps. Then we're going to flip them over and we're going to provide 5 chest thrusts. We're going to continuously repeat this until either the treatment is effective or that person becomes unresponsive. If our victim becomes unresponsive while we're trying to help them with that foreign body airway obstruction, then we want to immediately activate the emergency response system, either by using your mobile phone or sending someone else for help. After 2 minutes of CPR, if you are alone with no cell phone, you can leave that person to activate the emergency response system at that time. You want to lower the person to the floor if they become unresponsive and begin that CPR by starting with chest compressions. Do not even bother looking for a pulse. Before you deliver rescue breaths, we want to investigate the mouth. If you see the foreign body and it's in an area which can be easily removed, remove it. Because if you start providing rescue breaths, there's a chance you can push that foreign body back into the airway. You're going to continue CPR until advanced care providers arrive. The opioid pandemic has never been more prevalent than it is today. It's not only affecting our adults, but it's also affecting our children. So something that the American Heart Association really concentrated on when it came to the 2020 guidelines was opioid-associated emergencies for healthcare providers. The changes to the algorithm include respiratory arrest is more prominently addressed in the beginning with, "Is this person breathing normally?" An initial assessment with action steps is more clearly laid out with the initial "Is the person breathing normally?" question. If yes, the algorithm provides clear steps to prevent deterioration. Another big change was the naloxone. It's not as emphasized as it was before. In 2015, it was a standalone box with recommended doses. In 2020, it is under prevent deterioration and start CPR as consider naloxone with no doses. If a patient with suspected opioid overdose who has a definite pulse but no normal breathing or only gasping, such as respiratory arrest. In addition to BLS, it is reasonable for providers to administer intramuscular or intranasal naloxone. For patients known or suspected to be in cardiac arrest, in the absence of a proven benefit from the use of naloxone, standard resuscitation measures should be taken over naloxone administration with a focus on high-quality CPR. So let's take a look at the new algorithm. So this is the new algorithm for the opioid-associated emergencies for healthcare professionals. We begin with step 1, suspected opioid poisoning. We're going to check for responsiveness, shout for nearby help, activate the emergency response system either by using our mobile phones or asking someone else to do that. And we want to get naloxone and an AED if it is available. Step 2, this is the big change, is the person breathing normally? If they are, we move on to step 3, prevent deterioration. We're going to tap and shout, we're going to open the airway and reposition, we're going to consider naloxone, and we're going to transport to the hospital. Ongoing assessment of responsiveness and breathing, you will always go back to step 1. If the person is not breathing normally, the next question is, does the person have a pulse? And again, we're going to assess for no more or equal to 10 seconds. If they do, we want to support ventilation. We're going to open the airway and reposition, provide rescue breathing or bag mask device, and we can give naloxone. If they are not, we're going to start cardiopulmonary resuscitation, use an AED, consider naloxone, and we're going to refer to the BLS cardiac arrest algorithm. I hope that this video was helpful in understanding the 2020 American Heart Association updates when it comes to the basic life support certification. If you have any questions, make sure that you leave them down below. I love answering them. Make sure that you're following me on my social media. I'm on Facebook and Instagram. And make sure that you're subscribed here on YouTube and turn on that bell notification so you're informed every time I post a new video. Go over and check out my website for all of the algorithms when it comes to the basic life support at www.nursechung.com. But until next time, I hope that y'all are having a wonderful day, and I will speak with you all again soon. Bye!